Hi guys, this is Alicia with Good Morning Sunshine. So today I had 4 lectures. I'm going to go over 3 of them with you because one was over a recording. And then we also had lab today on epidemiology. So we had 2 lectures on bacteriology, and then we had 1 on clinical path. So I'm going to start with bacteriology today, just to get that done with because it's a lot of material. So we started with the production of disease. We just have to know the definition basically of disease. She doesn't care about the endogenous infections or exogenous infections, but I'll tell you them anyways. But anyways, a disease is an abnormal condition affecting the body of an animal, which may be caused by external factors such as microorganisms, and that equals infectious disease. So there is endogenous infections that arise when bacteria that live on the skin or mucous membranes take advantage of impaired host defenses and behave as opportunist pathogens. But then there's also exogenous infections, which occur after direct or indirect transmission from an infected animal or the environment. And then we went over pathogens again. It is parasitic and saprophytic bacteria, which have the potential to cause disease. So those are called pathogens. However, pathogens don't always cause disease. So for a bacteria to act as a pathogen, it must find an appropriate niche within a host. At times, it must compete with normal flora to gain a foothold in that niche, and it must evade or overcome the normal host defenses. And it must express genes that encode the virulence factors that cause disease. So basically, the ability of a bacteria to damage a host is called pathogenicity. The relative capacity of a pathogen to damage a host is the degree of virulence. So we also have opportunist pathogens, which is a term used to describe organisms that include bacteria that are living as normal flora on a host in their normal habitats, but can cause disease if this tissue is altered. So if it becomes damaged or if they gain access to other sites or tissues. An example would be E. coli lives in our gastrointestinal tract, but can cause disease if the gastrointestinal tract is damaged, or if the E. coli invades a site where it does not normally live, like the bladder. And then we have saprophytes that are bacteria that live in the environment, and those may also be opportunist pathogens, and most bacterial infections are caused by opportunist pathogens. So we have predisposing factors for infections by opportunist pathogens. Factors predisposing to opportunist pathogens include factors such as causing impairment of the host defense mechanisms or the principal factors leading to opportunist infections caused by normally harmless normal flora or saprophytes. And then we have factors such as the introduction of microorganisms to body sites where they're not normally found. And then we have the disturbance of other normal flora, by an antibiotic treatment. So we have obligate pathogens. This term is used to describe an organism that must cause a disease in order to be transmitted from one host to another, and these bacteria must be also infect a host in order to survive. So they will not survive if they do not infect. So in contrast to other bacteria that are capable of survival outside the host, these bacteria or pathogens need a host. So therefore, they are only isolated from an animal when they are connected with the disease. Fortunately, these types of bacteria are relatively rare. So then we got into host bacterial interactions. We got into pathogenicity, which is the capacity of the bacterium to produce disease in a host. In bacteria, it is inherent genetic capacity mediated by specific virulence factors. So then we got into virulence. This is a measure of the degree of pathogenicity. So it's a qualitative trait and represents the extent of the pathology caused by a microorganism. So then we got into host tissue compromise, which factors causing impairment of the host defense mechanisms are the principal thing that lead to the opportunist infections caused by normally harmless normal flora or saprophytes. So then we got into bacterial numbers. So the number of a potentially pathogenic bacteria present will also affect the production of disease. So in general, the more bacteria that are present, the more likely the disease will occur. But this is affected by the virulence of the bacteria, of course. So highly virulent bacteria require fewer organisms to produce the disease, whereas weakly virulent bacteria require many organisms to produce that disease. So this was her favorite slide, I guess. So this basically explains virulence here. So highly virulent bacteria takes little or few things in order for the disease to take place. And then moderate, you have intermediate requirements, and then weakly virulent takes a lot in order for the disease to occur, if that makes sense. So then we have defense mechanisms of the host that prevent disease. So both nonspecific or non-immune or innate and immune host defense mechanisms play a role in preventing bacteria, especially opportunist bacteria, from producing the disease. So then we got into nonspecific innate defense mechanisms. So I've already talked about innate immunity before from my immunology lectures, but so we have pathogen-associated molecular patterns known as PAMPs. This is when a pathogen enters a host, it immediately encounters cells that line the portals of the entry of the body, so the skin and mucous membranes. These sentinel cells display receptors that recognize and bind to a pathogen, associated molecules also called the pathogen-associated molecular patterns, or PAMPs, like I just said, which may differ between bacteria. Sentinel cells include mast cells, dendritic cells, the Langerhans cells, and macrophages. Binding of the PAMPs to the receptors on host cells triggers sentinel cell activation and production of pro-inflammatory cytokines. Remember if I talked about interleukin-1 and tumor necrosis factor. So then we skipped over that because we've already talked about it and learned about it. Like phagocytosis, the natural killer cells, if you remember those, the T cells, and all of that. So then we got into specific defense mechanisms. So these specific defense mechanisms involve the immune system or acquired immunity. Remember, 95% of bacteria or pathogens are resolved by innate immunity, but if we get to the acquired immunity level, they also do 5% that take care of us. So we have the antibody-mediated immunity, so the AMI. So this is lysis of the bacteria through a combined action of the antibody and complement to form a membrane attack complex. This is also known as a MAC and MAC. And then we have the neutralization of toxins and opsonization. If you remember, that's the natural ketchup. Together with the complement with subsequent phagocytosis and killing. So phagocytosis, remember, you just eat the bad cell, pathogenic cell. And then we have cell-mediated immunity, that's CMI, and that's the destruction of intercellular bacteria by activated macrophages, and it's the direct killing of bacteria by cytotoxic T cells. So then we have factors modifying host defenses. There are a variety of which can influence the host and predispose to the development of infections. So we have species, sex, and age. There are great differences in the susceptibility of different animal species to infection with specific bacteria of their toxins. For example, tetanus toxin causes severe disease in horses, but birds are resistant to this disease. So it depends on the animal as well. So likewise, there are differences in susceptibility among individuals and between males and females of the same species. Finally, age is also an important factor where, generally speaking, infectious diseases in both animals and humans are more severe on the extremes of life, so very young or very old. So then we have stress and stressors. So the term stress is frequently used to summarize various factors that contribute to the development of infections. However, that's not true. We can't do that. So if you're going to say that stress predisposed to the development of an infection, you must specifically identify the stressor. The stressor being extremes of the temperature, hot or cold, wounds, etc. So although mental stressors may lead to infections in some cases, this is much less common in animals than in humans. So then we have common physical or environmental stressors that predispose to infections that include tissue damage, so either direct damage, so that means like direct trauma, or damage produced by other infections that includes like parasites or fungi, or diseases such as allergies or endocrine or metabolic disorder. And then we have immunosuppression, which are both primary immune deficiencies. This includes failure of passive transfer, And we have secondary immunodeficiencies such as Cushing's disease or cortisol therapy. So then we have sources of bacterial infections. There are a number of different sources of the pathogenic bacteria which may cause disease in domestic species. So knowledge of the source is very important for us as it allows us to prevent further transmission of infection to other susceptible animals. So the most common sources include normal flora, that being the normal bacterial flora of an animal may be the source of infection, particularly in the opportunist infections. Some of the most important pathogens are included in this group. This is Staphylococcus, and then some Streptococcus, and E. coli. So we have animals incubating a disease. The incubation period of a disease is the time that occurs from when an animal is infected to when the clinical signs appear. So during this time, the animal may appear healthy but may shed the causative agent and thus transmits the infection to other animals because they don't realize they're shedding it because they're in the incubation period, so they don't have signs for it. And then we have animals with overt disease. Usually the highest numbers of bacteria are shed when an animal displays signs of the clinical disease. So the routes by which they are shed depends on the location of the infection. It also depends on the extent and duration of shedding, because this varies with different diseases and could be short, meaning acute, or so that's like anthrax, or prolonged, so chronic, like mycobacterial infections. Alternatively, some animals with overt disease may not shed bacteria at all. So then we have animals with subclinical infections. So animals may acquire pathogenic bacteria from infected animals without contracting the disease themselves. And then we also have carrier animals, which in some infections, bacteria may continue to be shed even after resolution of clinical signs. These animals are called convalescent carriers. And then we have inanimate sources. So some bacteria exist in a free-living state in soil or decaying vegetation, such as saprophytes. In these cases, it is the environment that is the source of infection. Also, the term fomites refers to the inanimate object or substance that is capable of carrying infectious organisms and therefore can be a source of infection. So then we got to the transmission of bacterial infections. So infectious agents are most frequently transmitted to new hosts by direct or indirect contact. So direct spread occurs when an animal has contact with infectious discharges which form affected animals. So this being nasal discharge, skin, or semen. And then we have the indirect spread, which is more common and occurs when the organism is shed or excreted by the host and contaminates the environment. This would be like food, water, litter, air, or dust. And then we have organisms enter the host by one of the following portals of entry. So we have inhalation, which is an infection via the respiratory tract, so you inhale it. We have ingestion, which is via the alimentary tract, where you basically ingest it, eat it. And then we have the inoculation or infection through the skin or mucous membranes by simple contact, such as injections, such as biting insects, contaminated hypodermic needle or syringe, or wound infections. So then we have via the genital tract during coitus, and via contaminated instruments, catheters, and semen. And then we have transplacental infection, which is via the umbilicus. And then we have venereal. So then we got into bacterial virulence factors that cause disease. So the bacterial traits that confer pathogenicity are called virulence factors. So then we got into the genetic variation of virulence. So this is the process by which bacteria can switch on and off the expression of a gene product. It's called phase variation, which is an extremely important attribute of pathogenic bacteria. So virulence factors, so in general, bacteria can only cause disease if they, so there's 4 things: if they find an appropriate niche, compete with normal flora to gain a foothold in that niche and then attach, so colonize. Second, they usually then gain access to the tissues, so they invade. Third, they have the ability to survive inside the host tissues, so they can sequester iron and subsequently invade the innate or immune defense mechanisms. And then 4th, lastly, they produce molecules, toxins that cause tissue damage, like cell lysis, or cause dysfunction. So each of these processes are described in more detail. So adhesion, we're going to get into adhesion first. So the pathogens use adhesions to attach to host tissues to colonize and to resist the flushing action of body fluids. Thus, adhesion plays a significant role throughout our course of infection. So pili are the specific structures found on the surface of some bacteria, particularly gram-negative bacteria, that assist adhesion to a cell surface through a specific interaction with cell surface receptors. So then we get into invasion, our next step. So bacteria may actively or passively invade an animal host. So they have passive entry, which occurs when there is some damage or compromise to the epithelial surfaces of a host, so the skin or mucous membranes, and the bacteria can enter via this route. Or there's also active entry, which occurs when the bacteria cross an intact surface and usually occurs in the gastrointestinal tract and to a lesser extent in the respiratory and urogenital tract, and also the conjunctiva, which is not as common. So then we got into iron sequestration, which is the availability of iron. It's a limiting factor for growth bacteria because they need iron for their electron transport systems. So most iron in the animal body is unavailable to bacteria as it's bound by the iron binding proteins such as lactoferrin or transferrin. However, many pathogenic bacteria have evolved mechanisms for obtaining iron from their host, including iron chelating agents such as siderophores, which can remove iron from the transferrin or the lactoferrin. So then we got into anti-phagocytic molecules such as the capsule, the slime layer, the M protein, and biofilms. Once inside the host tissues, pathogenic bacteria may use anti-phagocytic surface structures to avoid phagocytosis and killing by professional phagocytes, which is one of the main innate defense mechanisms against microorganisms. These structures are found principally on the extracellular bacterial capsules. And then capsules are the best studied of these molecules and encapsulate organisms. The M protein on the surface of Streptococcus equi may act in the same role as a capsule in having anti-phagocytic properties. And then we have bacterial biofilms, which may be formed on a variety of surfaces, such as epithelial, teeth, or medical devices, and where they assist bacterial colonization. So then we have intercellular survival, which are intercellular parasites, which is the ability of some bacteria to survive inside cells, is another mechanism whereby bacteria can avoid the host defense mechanisms. In this way, they are able to avoid being killed by phagocytes, avoid being neutralized or killed by the antibodies, and in some cases, avoid being killed by antibiotics. And then we have facultative intercellular parasites, which these bacteria are not confined to cells but can survive and in some instances multiply in phagocytic or other tissue cells, such as epithelial cells. And then we have obligate intercellular parasites, which these bacteria can only survive and multiply inside cells. The preferred cellular location varies depending on the organisms. So then we have bacterial toxins, which bacteria can damage host tissues directly through the effects of exotoxins and endotoxins, or indirectly through the tissue inflammation generated in response to the bacteria, and particularly through the activity of enzymes and other toxic molecules released upon lysis or phagocytes, and often caused by the action of some exotoxins. So there's differences between exotoxins and endotoxins. This is the chart on it. I'm not really going to read it to you, but this is the chart as you can see here. And then the effects are different for exotoxins and endotoxins. And then we started our next lecture of bacteriology, so the third lecture. So we went over the diagnosis of bacterial infection, so there's many steps to go through. I think we got through the first 4 that I'm going to teach you right now. So step 1 is to determine if the patient has a treatable microbial infection. So a key decision that should be made early in the diagnostic workup is whether the patient's condition is due to an infectious etiology. So evidence of inflammation is usually central to this process, but you also need to remember that inflammation may have a variety of causes, which require different treatments. So we look for clinical signs. So these include like fever, pain, heat, swelling, loss of function, and discharge. They are suggestive but not pathognomonic for bacterial infections. And then we have clinical pathological findings consistent of bacterial infection that include increased total white blood cell count with neutrophilia, the possible left shift with toxic changes, increased fibrogen and other acute phase protein concentrations, and hyperglobulinemia. So then step 2, we want to create a list of likely infectious agents, including bacteria that could be causing the disease you deserve, and determine if bacterial identification is required. So once you have determined that a bacterial infection is likely to be present, you should create a list. So the next decision is whether you need to make a presumptive diagnosis or whether a definite diagnosis is required. Or a definitive diagnosis is required. So this decision will be influenced by the possible infectious agents, the infectious process present, and the host animal. So presumptive diagnosis can be made in some cases based on history, signalement, and clinical signs. Clinical signs that are typical of a single cause of disease or type of infection are said to be pathognomonic, such as tetanus. And then in some cases, a presumptive diagnosis of a bacterial infection is sufficient, and the animal can be placed on an empirical antibiotics if they're indicated at the times when our presumptive diagnosis is indicated. These include when we have a pathognomonic clinical signs and the treatment of these infections is standard, such as tetanus, or when the infection that is presumptively diagnosed usually responds well to the empirical therapy. So there's uncomplicated bacterial cystitis in dogs, and then a cat bite, abscesses, and surface and superficial pyoderma in dogs. Or when the client doesn't have enough money for further diagnostic testing. However, but we need to at least offer the diagnostic step, so you shouldn't assume they don't have the money for it. And then in other cases, a definitive etiological diagnosis may be required in order to identify the causative agent and potentially perform antibiotic susceptibility testing. The situations like this, when pursuit of a definitive diagnosis, includes when the animals are very young or very old, when animals are critically ill, especially if they are showing systemic signs of infection, suspected infection in a difficult to treat site or has serious consequences, such as the bone, joint, or brain. Suspected bacteria pathogens don't have predictable susceptibility pattern or rapidly develops resistance, or an infection has not responded to earlier therapy, or if you suspect a notifiable disease such as anthrax, plague, or tuberculosis, or if it has an outbreak of a disease in a herd situation such as strangles or leptospirosis. So then step 3, if a definitive diagnosis is desired, determine the preferred diagnostic test to identify the suspected bacterial pathogen causing the infection. So there are a number of ways bacteria can be definitively identified. So these include a collection of a sample and identification of the bacteria through direct visualization of organisms in a smear due to distinctive features, or the cultivation of the bacteria and identification using route line laboratory techniques. So there are a number of ways. So there's 4 ways. That was one way. The second way is the detection of specific antibody to the bacteria, such as serology. The third way is the detection of specific bacterial antigens, including toxins. And finally, last is the detection of specific bacterial DNA. So then we got to step 4, our last step that we got to. So despite the best intent, so step 4 is recall the common problems associated with a sample collection. So despite the best intentions, there are a number of common pitfalls associated with a sample collection, which can adversely affect the outcome of this procedure. These include multiple and often poorly accessible sites for collection of samples. It includes contamination of samples with indigenous noroflora, and the failure to consider the diversity of bacterial agents which may be involved, and therefore collect the sample incorrectly or transport the sample incorrectly, not allowing the bacteria present to survive, the ever-present temptation to sample incorrect. So that's where we stopped on bacteriology for the day. And then lastly, again, we ended with clinical pathology 2, which is blood loss anemia. So I think we actually finished the lecture from yesterday. So let me try and pull that lecture up before I start this one. Because I think he talked about anemia. I didn't get to anemia yesterday because he didn't finish it, but he finished it today. So anemia general is the onset. So we got into the onset and severity of anemia. So the pathogenesis is tissue hypoxia. Its history is lethargy and exercise intolerance. On physical exam, you would see pale mucous membranes, hemodynamic compensation, splenomegaly, or hepatomegaly. And its general concepts for anemia is hyperplasia, with atrophy, which is non-regenerative. It's a decrease in reticulocytes, neutrophils, and platelets. There's also hemorrhage, which is regenerative. It's a visual evidence of blood loss. So you'd have an increase in reticulocytes, but the plasma protein concentration is usually decreased. And then we have hemolysis, which is also regenerative. So you'd see an increase in reticulocytes, and plasma appearance protein is still normal though in this case. So then anemia has a regenerative status. So I'm just going to show you this actually. So here we have hemorrhage and hemolysis on this side, and then we have hypoplasia, atrophy on this side. So the onset is the same for hyperplasia and hemorrhage and hemolysis. However, 2 to 3 days in the onset, so it's more than 2 to 3 days, then that's when they differ in reticulocyte number. So then we got into hemorrhage and blood loss anemia. So acute hemorrhage, I'm going to show you because here's the example that he showed us. Let's see if I can do this. So in this picture, we have a plasma sample. So this was a laceration of a paw with a lot of blood loss. So we ran a PCV. The PCV could look normal because there was a loss of blood and plasma. So the loss of blood and plasma came in equal proportions. So that's why we have equal proportions here when we first sampled the blood. But then if we wait 24 hours, then the blood volume will increase and the plasma volume is restored. And red cell mass is still reduced, and in proteins, the plasma increases because it is restored. But after 2 to 3 days, we make up some of the loss of the red blood cells. And this will take about 2 weeks to go back to normal. So protein concentrations are also starting to come back up. So I'm going to summarize this for you. So here's our picture again, so you can look at the picture. But blood taken right after the incident, the hematocrit, so the blood cell volume and plasma are the same. But less than 30 to 60 minutes, the blood volume will drop as well as the plasma volume. But then more than 30 to 60 minutes, so like 24-hour periods, there's low hematocrit, but high plasma volume, because here the plasma is trying to be restored. So you'd have a higher plasma, but still a low red blood cell volume. But then 2 to 3 days, things are trying to go back up, back to normal. So then you can see it coming back up, trying to get to normal levels where blood loss and plasma are both equally proportioned. But then we have chronic hemorrhage, which has compensatory mechanisms, so there's no or mild clinical signs. The CBC results dependent on the body's iron stores. We have internal hemorrhage, which that doesn't have iron deficiency, whereas external hemorrhage has iron deficiency. So no iron deficiencies, it looks like hemolytic blood loss, like an anemia, whereas when there is iron deficiency, this is when red blood cells go through an extra division, like I said, until they got hemoglobin concentration correctly. So then we have chronic external hemorrhage, which usually has to do with the GI tract or renal, or something is actively bleeding. So the iron store goes down, the reticulocytes are regenerative, but then become non-regenerative. The MCV goes up and then down. The PCV, so packed cell volume, continues to go down, and the MCHC continues to go down as well. And then we have chronic external hemorrhage, such in dealing with iron deficiency. So again, regenerative to non-regenerative. There's a hypochromia present. Red blood cells are more fragile in this case. They break easily. And then we have, I'm going to butcher this word, but it's poikilocytosis, which is variation in red cell shape. And then we have anisocytosis, which is variation in size. And then we have the increased number of platelets, which is known as thrombocytosis. So these are what the cells look like for iron deficiency. So then he got into a few cases, but I don't have those yet. He said he was going to post those later. So, and then again, I had my epidemiology lab. But yeah, that was it for today. Just trying to get through the day. I just got home actually from lab. The lab actually did take 2 hours, so that was kind of frustrating when it only should have taken like 1. But it was all math stuff. Basically, we were looking at outbreaks for epidemiology and what causes an outbreak and why there was this outbreak. So that's basically what we were going over in lab today. But yeah, I love you guys, and I hope you guys had a good day today. And I can't wait for tomorrow. I have Lillian over there. She's sleeping. I actually don't know why she came up here. She's usually not up here with me. So, but Grandma's also not home yet. So, no reason to go down there, I guess. But yeah, I'm gonna get ready to feed them and then probably go for a walk. But I love you guys, and I thank you guys for listening.